One of the exciting parts of this conference that we always try to incorporate is a panel discussion. Over the years, the panels have taken different shapes, and this year we're really delighted to have a panel of experts who will offer their perspectives about today's topic, which of course is 30 years of research and where are we going from here. So the game plan for this section of our conference is that I'm going to briefly introduce you to our illustrious panel. I'm going to ask one or two questions of each of them, and I hope you will see that there are thankfully a diversity of stakeholders in the research enterprise at UCI and beyond, and they all have their unique perspectives on what we are doing and trying to accomplish. After I do a handful of questions, we are going to open it up to the audience. So as you're listening to the beginnings of this discussion, we hope you'll think about questions you might have for these different stakeholders. And then at the conclusion of this section, we're going to take a coffee break and another resource fair. So working from my left, I'm going to introduce this esteemed panel. I'll begin with Cleo Doherty. Cleo spent 40 years as an independent representative for artists and manufacturers in the toy industry, and she is now a caregiver to her husband with Alzheimer's disease. Next, we have Mr. Richard Carpenter. Mr. Carpenter is a participant in an investigational clinical trial to see whether physical exercise can improve memory. Next, we have Beatrice Vides. Beatrice is a nurse who began her career at UCI MIND in 1999. Yes, she was 2. And she now is a central figure in our clinical trials program, coordinating most of our trials. Next, we have Dr. Elizabeth Head. Dr. Head is a neuroscientist who was recently recruited back to UC Irvine from the University of Kentucky. And she holds prominent roles in our Alzheimer's Disease Research Center, our Neuropathology Core, and in our Down Syndrome research program. And last but certainly not least, we have Dr. Lisa Gibbs. Dr. Gibbs is a professor in the Division of Geriatrics in the School of Medicine at UC Irvine, providing care to older patients here in Orange County. So we have a very diverse array of different stakeholders in our research enterprise. And I'm going to begin by giving each of them an opportunity, beginning with Cleo, to tell us a little bit about their story and what brings them to be with us today as a research stakeholder. So Cleo, do you want to begin?
I came into this accidentally, like I think we all do. My husband and I were just buzzing along with life. I was running a business, he was working and traveling too, and we had a daughter at home. And he was quite young actually when this happened, but he had a massive TIA while he was on a business trip. And the exams that followed showed that he had Alzheimer's. So that everything turned upside down. And life changed, but I became a caregiver through the help of ALZOC, where they train you to be a caregiver and they give you support. And my husband had the socialization and the help he needed at that time too. It has been a very long journey. He's in his 14th year and he's in residential care, and I'm trying to move on with my life and be a caregiver too. Thank you.
Thank you, Cleo. I think we can give each of our speakers a round of applause. Richard, could you tell us a little bit about your perspective and what brings you here today?
Okay, what brings me here today? I was going through the mail one morning and I got a postcard from UCI, and it was addressed to me personally, like they knew something was going on. I don't know. But I read it real quick to my wife, and then I reached over to put it in the recycle file, and my wife, her quick reflexes is why I'm here today. She said, wait, what did that say? Next thing I know, she's on the phone to UCI, and I'm in this program now. This was late last year, about a year ago, and I went in for interviews, all kinds of medical tests, blood tests, MRI, EKG, you name it. And the good thing was that out of all that testing, they didn't find anything wrong. Slight pause for a man my age. I went to see, and I started the program in January, and I go to the gymnasium 4 times a week. I have a trainer for 2 of those 4 days for the first 12 months, and then for the last 6 months, my total obligation is 18 months. For the last 6 months, then I'm totally on my own. But I'm very motivated to see this through. I think it's very important not only for me personally, for what I can get out of it, but to help a program that can help a lot of other people. Well, offhand, that's about all that comes to mind.
That's great. That's great.
Hi, everyone. My name is Beatrice, and I started here at UC Irvine in 1999 when I was an undergraduate. I needed a job, and I was really interested in working in the healthcare field, so I decided to apply for a student assistant position with UCI MIND, which was called something else at that time, and I've been there ever since. I was offered a full-time position in 2002 after I graduated to essentially act as a recruitment coordinator and backup coordinator for our clinical trials unit, and I gladly accepted. Went back to nursing school and never left UCI, just kind of moved up the ladder, and recently completed my master's degree in nursing, and I'm still here enjoying what I do.
I'm Liz. I started at the University of Toronto without any intention of becoming a researcher in the Alzheimer's disease field. And through a rather convoluted story, I landed down here at UCI with Dr. Kottman as my PhD mentor. And Dr. Kottman introduced me to Dr. Ira Lott, who does a lot of work with older people with Down syndrome. So the reason I'm in this field is just because I love people. I think the research is fascinating. I like to work together with all of you to kind of find a cure, to make things better in the long run, with the eventual goal of hopefully finding a cure for Alzheimer's in collaboration with, of course, an international community, and then I can retire.
Hi, thank you. So when you talk about research stakeholder, I'm not in the business of finding a medical cure. I'm in the business of improving health care for people with persons with dementia and their caregivers. What led me here, I think, was initially going through a family medicine residency and then coming upon, patients with dementia. I really had not enough training. I really had not enough training to have the awareness of persons with dementia and their caregivers and their needs. And it's really the patients that I really fell for. 2 in particular. One was a gentleman who came in with his wife, and she had moderate to advanced Alzheimer's. And he was so concerned about her that he really neglected his own health. And he would come in and he would say, well, I have this neck pain, but we can talk about that later. And so we ended up focusing on her until the day came when we just couldn't ignore this anymore, and it turned out he had metastatic prostate cancer to his spine. So at that point, that was a real wake-up lesson for me, that we can, sometimes not attend to the caregivers as much as we should. And then the other patient was a Spanish-speaking woman who came in with her family, and because she was Spanish-speaking, they spoke for her. And then it took me a very long time to figure out that she had dementia because I wasn't speaking directly to her. And I think these 2 interactions had a profound effect on me, and at some level I decided, eventually to go into geriatrics, and that things like this shouldn't happen and someone had to do something about it. So that sort of led me to where I am today.
Thank you. So everyone has their own path as it relates to our mission. And I just want to ask people to think about the beginning of their journey and whether you had specific expectations for your journey and how research may play a role in that journey, if that applies to you, and whether those expectations were met. Cleo, you want to start us off?
It was such a shock
Do you wanna-
sorry. It was such a shock to have this diagnosis come when it did, that I had no expectations because I really had no knowledge of Alzheimer's. I did know that it came down through my husband's family and that I had met Uncle Jimmy, but I really had no expectations. So I was just coming in
And did
blind.
anyone talk to you about whether research might be right for you at the beginning of that journey?
Yes, we actually started doing some research of our own, just trying to figure out where do we get help. And we went to the Alzheimer's Association and were greatly helped there. And also we attended a symposium where we learned that, we heard 3 wonderfully brave people talk about how they were affected in their work by Alzheimer's when they were very young. I should say there was 3 people who had Alzheimer's early stage, enough early that they could come and do the symposium and talk about how it affected their work and their lives. And that was our introduction to, we needed to learn more and to get involved in trying to help my husband and myself too.
Thank you. Richard, when you began the exercise study, did you have specific expectations? Major muscle growth?
Well, I'd rather get rid of fat growth rather
Get rid
than
of that, yeah.
Yes. I had 2 expectations, one for me and one for the program. For me, the more I learned about the program, the more I wanted to do for myself. And I guess if I had to say one word more important than any other, it would be motivation. I was motivated to look at everything I do, largely what I eat. There were things I would eat every single day that I have not touched since last December. As a result, after 10 months in the program of going to the gym and changing personal habits, I've dropped 10 pounds. That doesn't sound like much, but I'm hoping at the end of the 18-month commitment, I will have dropped 20 pounds. And for me, that's very, very good. As far as the program, anything that I can do, because what I do is logged in. My trainer logs in numbers of what we do. And if at the end of 18 months, they can derive something out of what's been happening to me that will help the program, then I think that's wonderful. I've known people who have had memory issues. My own father had severe memory issues before he died. And as a result, when I started to develop memory issues that I could recognize, I went to my doctor. I was sent to a neurologist. I got an MRI, and the MRI showed that I had mild cognitive impairment. And there's a pause, and I say, for a man my age. I'm really tired of everything relative to me ending with for a man your age, but that's what it was. And I realized I had a problem, and then it'll come this card in the mail. It was almost like it was predestined somehow. And I'm hoping to get a lot out of it personally, and I hope what I do and what happens to me and what they learned from me will help the program in total.
Great. And Beatrice, when you began working in a program where the goal was to develop treatments for Alzheimer's disease, did you have specific expectations?
Well, first off, I didn't know anything about clinical research. I didn't know that human research existed. All I thought about when I thought about the word research was people in a lab testing things on mice or other types of animals, but I never knew that human research existed. So my expectations were pretty low. But when I first started working on clinical trials, I didn't expect to still be looking for a cure 17 years later, or working towards a cure 17 years later. But with that being said, I think we've taken some really good strides towards just better understanding this disease.
Liz, you alluded to the fact that we're going to cure this disease so you can retire. Did you think we would have already gotten there when you began studying aging brain?
Yeah, that was one of my expectations for sure. I thought, well, especially being here at UCI, and I'll just say that in a very biased way, I really thought there was just fabulous research here and that we'd make some really great strides, and I think we did. but there's been a lot of setbacks. So in terms of research expectations, that's one of the ones that didn't quite meet my expectation. On the other hand, there were several things that exceeded my expectations, and that was the people involved in this field. What surprised me, I always thought the Alzheimer's disease world was very competitive because there was a limited amount of funds for research. So, and that was true to a certain extent, but as you saw in some of the graphs today, the funding's much better. And that's led to a more team science approach to finding a cure for Alzheimer's disease, and I think that's just magical. It makes life easier, it makes it more fun, more engaging, and I think it also means well for our next generation of scientists because they'll be more engaged because we need them to continue this work for us. So I've had both goods and bads in terms of expectations.
Dr. Gibbs, taking care of people with memory problems, did you have expectations of researchers?
I did, and I've seen medicines come and go and come and go. And in fact, in residency and early fellowship, I think the atypical antipsychotics were just coming out, risperidone, and selegiline, and names that we don't talk about these days. But yeah, I mean, it just I think my appreciation for how complex this disease is, not just Alzheimer's, but all dementias. Each one has its own complexity, and as we dig down, we find more and more and more. And so this is not an easy fix. But from my point of view, I have a very rewarding practice because we focus on holistic care, and we understand that this is not, a death sentence. For us, this is a chronic illness, and it's not a sprint, it's a marathon. And so we study how to be there for the patients that we serve and our caregivers. I think also I've really deepened my understanding over how this is a problem for society. We need public health policy, we need our community resources, we need our researchers, but we need healthcare delivery systems. I mean, this actually touches every segment of society, and not only the expense for caregiving, but the treatments and the hospitalizations and the extra care that's needed. So it's just huge. So my appreciation for the complexity of a problem in all aspects, I think, has really deepened over the past 15 years.
I could say personally as a stakeholder that I'm going on 15 years of saying with complete sincerity that I believed within the next 5 years we'd have a treatment that could actually slow the course of Alzheimer's disease. And I believe, by the way, that in the next 5 years we'll have a treatment that can slow the course of Alzheimer's disease. And I think the other thing that was unexpected for me was just how much I would learn from the people participating in our studies. And the people like Richard and Cleo who've enrolled in our studies, and I've had admirals in the Navy who had their own aircraft carriers, and I've had people who told me that they had PhDs of the sidewalk, and I learned from all of the people who have enrolled in our studies over the years, and that's been absolutely one of, if not the most rewarding parts of being involved in a research center like UCI MIND. So our panel has agreed to take your questions, and we hope that you'll have some. I have more that I can ask them, but at this time I'm going to open it to our audience, which, by the way, this year is an all-time high of 470 people expected to be here today.
Question on the exercise. So if you're 20 pounds overweight but exercise every day, is that better for you at normal weight and no exercise?
Carl, you want to come back up? Or I would actually, if Dr. Gibbs wants to speak to that, I think that there's no question that physical activity is good for us, and that an ideal weight is also good for us. And so I think we should try to achieve our ideal weight and exercise. Is that a good way of not answering that question?
Yeah, this is a great way. That's
Thank
very
you.
good,
Thank
Josh.
you.
It's wow. I would rather, if my patients were overweight, I would rather have them exercise every day rather than achieve an ideal weight. I mean, it may depend on how overweight we're talking about, but I just believe mobility is one of the key factors to staying healthy. I mean, without exercise, with exercise, you're basically bringing nutrition to every part of your body. And without exercise, you're not. So to me, I'd rather have somebody be somewhat overweight and exercise every day. And I would think that person might be healthier than the other ones. Now, I don't know if you can go to the literature and find this today, but this is what I would say if you know, a patient asked me that question.
Thank you. That's one. Go ahead, I'll repeat it.
I'm 82, but I exercise only 2 or 3 times a week, riding my electric bicycle, and I find that brings me back a lot. My wife, who has Alzheimer's, is just beginning to accept the fact that she should exercise to keep her mind as well as possible. What else can we do?
Yeah, so the question is, if someone is in the early stages of Alzheimer's disease, physical activity is clearly something we recommend for people with or without Alzheimer's. What else could that person be doing? I have some thoughts, but do you want to get us started?
Sure, I'll pass it on. You know, everything that we can do to take care of our heart means that we're taking care of our blood vessels. So you take care of your heart, you're taking care of your mind, you're taking care of your kidneys, etc. So exercise, diet, you know, we do point to the MIND diets, the Mediterranean diets, the DASH diets. Social stimulation for our patients that are starting to have some difficulties is extremely important. Just that act of interacting, not being, I mean, isolation is evil as far as I'm concerned. So anything we can do not to be isolated as older adults is extremely important. Yeah, I mean, I think, you know, continuing to utilize your mind and different parts of your mind is really important.
Yeah,
so
great.
that would be my clinical guidelines, but I'll pass it on to you.
Cleo, if someone were in the beginning stages of Alzheimer's disease themselves or in their family, what advice would you give to them? Not medical advice per se, just about the journey.
The first thing, unfortunately, is to get your ducks in a row.
Yeah.
Legally, financially, emotionally, talk about what you really want and what your plan for life was and how you can make that go forward in a bit different path, but still what you would want. And keep your mind busy, keep your body busy. I mean, I never exercised a day in my life until I was well into seniorhood here. And I feel so much healthier just in these last few years for doing that. My husband was a jogger up till the day he was diagnosed. But he had a different situation. I just think that I would ask people to keep your mind active, keep your body active, eat properly, don't smoke, drink very little, if at all, and try to enjoy your life.
Dr. Kawas is here. She's saying a little's okay. And we heard today that we don't have good enough therapies to offer people who get a diagnosis of Alzheimer's disease, but I agree with you that this is an important diagnosis. And Dr. Schneider talked about some really impressive work out of Rush where they showed that people with Alzheimer's disease are at tremendous risk for financial errors, susceptibility to scams and fraud. So there are a lot of steps that can be taken to try to plan and be prepared for the journey that lies ahead. And we're really lucky to live in a place with Alzheimer's Association, Alzheimer's Orange County, and other organizations that join us today to help us with that journey. So there were lots of hands, which is great.
I would like to address Dr. Gibbs. I am so pleased to see that you're involved in clinical geriatric medicine. We need so much more of that here in this area and in Orange County. And you're head of the UCI MIND Center. Is that the one over in Orange?
So I direct the UCI Senior Health Center. Yes, that's on the Orange campus at the medical center.
Okay, because your Dr. Tam and Dr. Oak, whom I've seen on several occasions, know how to speak to seniors. They know how to address seniors with respect and bring out maybe things you would be hesitant to say to some doctors who don't seem very interested. I live in the used to be Leisure World, in the Laguna Hills Village, about 12 miles south of here. We have 18,000 people, age 55 or older. It's an age-restricted community. So we see maybe more Alzheimer's victims than you do in most of your local neighborhoods. And we need geriatric doctors. I hope you will encourage some of your graduates to come and start a practice in our area. I hear from different neighbors, because I've lived there 26 years, so people like to chat with me. I'm not an official of the village at all. And I hear from different neighbors and people that they go to see their doctor when they're first suspicious of something that may turn out to be innocent and may not be, and they just don't feel appreciated or tolerated or understood, and so they don't really share everything. Thank you very much for going into this field.
Absolutely, thank you. Can I add to that?
Yeah, well, I mean, we agree. Thank you.
Yeah, I do
Thank
agree.
you.
This is working. I just wanted to add that we did a survey about 5 years ago about how many geriatricians are needed in Orange County, and at the time we estimated we needed about 150, and we had 50. And within the next 5 years, half of those geriatricians were due to retire. So this is an imperative that we do have a geriatric fellowship. We're graduating at least 2 per year, and most do stay in the Orange County, LA areas. We have our eye on Laguna Woods. We would love to be able to serve more people. So one of our primary roles in some of our research grants is to really train primary care providers in the care of older adults, because we know there won't be enough of us, and we know primary care providers will be taking care of most of our older adults. So we are very invested in that as well.
Great, thank you.
Good afternoon. Hear me here? All right. Can you hear me all right now?
Give it a shot and I'll repeat it.
Good afternoon, Dr. Grill. You had said that you believe we're within 5 years of a treatment. You felt that way over the last 15 years. Is there a treatment today that you feel like we're closer to? And if so, has that changed over the last 15 years, of which treatment you feel we're closest to?
Feels like a loaded question, Jonathan. This is just one person's opinion, and I want to hear from others on the panel, but we've talked a lot about the data from Biogen today, and I think that aducanumab is on a path to getting approval. I don't know if the data that's available today will be adequate for FDA approval, but I think that the data are compelling, and that if another trial is needed and they look the same as what we've seen so far, that drug can and will be FDA approved as a potential disease-modifying therapy for Alzheimer's disease. And we heard today from Bill and others that there are other drugs that have been shown to be able to reduce the amyloid plaques. They haven't had quite the same correlation with clinical benefit, but certainly those remain interesting and hopeful. And so, yeah, I think that one of those could be the first disease-modifying therapies, and I certainly hope it happens in the next 5 years. And I really want to hear from Beatrice and Liz and Lisa as well.
So I think one of the more exciting things is the fact that we're getting such a good handle on risk reduction. And if you remember what Dr. some of her slides show, that just reducing risk for certain factors that we can control could potentially have a huge impact on brain aging. So getting high blood pressure under control, a lot of the co-occurring illnesses, it looks to me, based on a lot of these data that are coming out, that we can already start to bump our risk down substantially. And then when these drugs come out, we'll be in a much better position to zero ourselves out in terms of our AD pathology maybe one day.
I totally agree. I think, sometimes we find that dementia is not just from single pathology, but it's mixed, and a lot of it could be mixed with vascular issues. So completely agree, like the risk reduction is so important. And I just have the sense that if you do that, at least starting in midlife, it's even better. And just wanted to add sleep, the importance of sleep, to what we said before. There are so many undiagnosed sleep disorders, and sleep affects the way you think. So that's another, I think, risk reduction that we need to pay attention to.
I don't really have anything to add.
I just, my wife went to a residential care, under residential care. But I wonder if there is a right time or what stage of the Alzheimer's disease is the best time. Is there any best time to place her to a residential care?
That is the hardest question I've ever had to answer, because it was the worst decision I ever had to make. When it gets to the point where, I'll give you the plus and the minus. My husband desperately needed socialization, and he needed more attention and more monitoring because he would wander and take things apart. And I was trying to run a business and be a mom and run a house, and it was ruining my health. And when he went into residential care, and I thought I had thrown him under the bus, he actually just kind of perked up like he had a whole audience for his repertoire of bad jokes and little silly songs. So he needed that socialization so badly, and I hadn't thought about that. So they really need community. They need other people they can be around, and sometimes looking at their caregiver who's stressed out and worked out and getting sick themselves, it's not the best. So it's a very, very hard decision, the worst one I ever had to make. But it turned out okay.
Just, it seems to me there is the theoretical point. There's the right time to, depending upon the memory span the patient has. You know, all the people in the residential care doesn't want to stay there, want to come home. But in my crack theory, it depends upon her memory span. So it hurts me more than I guess, patient herself.
So thank you. Oh.
Go ahead.
You're both good.
Okay. It may feel like it hurts you more. I actually do a lot of volunteering at a residential facility, and yes, many people are still in the mode of trying to go home because they are not really sure where they're at, and they're just confused. So my job, and the job of the caregivers especially, is to redirect them and get them engaged in other things, to get them thinking in different directions, or just to lose that, needing to go someplace else. I think that goes away over time. Some people never have it. Some people just have it for a little while. But again, it's painful to watch, but it may not be as painful for them because they're in a safe place and they have excellent care.
Yeah, thank you for the question. And yeah, we've seen many families go through these excruciating decisions, but I have to say I don't think there's one answer for that. One person with dementia is one person with dementia. Everyone's different. Their caregiver situation is different. Every caregiver is different. Every caregiver patient relationship is different, and every family unit is different. So there may be at one point, which is earlier in the course, be best for some families to put someone in residential, and then for some families it's much later on. So it's really a discussion, an ongoing discussion. So I don't think there's any one right answer. It's really, the question is what's right for you and what's right for your wife.
We've heard a lot of talk today about the biological part of the Alzheimer's, but some of us have heard in the past that there are family risks, and there was no research presented today, but I'm wondering if anyone on the panel has information as to is there still a feeling that there's an increased risk factor for Alzheimer's if one or both parents or other relatives had dementia disorders?
So I think that literature is still being built up over time, because what that requires, especially when you look at risk of dementia within families, is large numbers of people. And but coming down to what might be the biological underpinnings for that is, I think, is a big unknown. But for example, with apolipoprotein E, which you hear a lot about as a risk factor, we're learning a lot about how that protein functions in the brain and its role, say, in cholesterol, that maybe one day will lead to, again, modifiable risk factors for us in the future. So all that to say, I think I personally cannot say exactly what the biological underpinnings are for that risk within families, but it certainly is an active area. And I don't know if Josh has some more info.
I mean, I think we're going to hear an amazing talk about lifestyle factors later this afternoon, and we've seen Dr. LaFurla and others present data around the many genes that have been identified as playing a role in risk, and of course we get our genes from our parents. And there are various estimates, but most arrive at around half of the risk being genetic and half of the risk being lifestyle. We get our genes from our parents. We often get our lifestyle choices from our parents as well. So there are numerous studies that say people who have a direct family history of Alzheimer's disease are at increased risk relative to someone who does not. But it's really just the beginning of the story, because lots of people who have a parent with Alzheimer's disease don't get it, and lots of people get Alzheimer's disease who didn't have a parent with it. So I think we've heard all day that this is a very complex disorder. We even heard from Dr. Schneider, it's so complex that we're just talking about Alzheimer's, and then there's all these other things that can happen in the brain as well. So I think we're going to hear more about that later today, and we can all take that as an hopefully instructive, like we heard earlier, to try to lower our risk any way we can. Right under the spotlight, at least for me, there's a hand up. I don't know how I saw that. We got a microphone, go ahead.
Yeah. All right, thank you. I think as physicians we need to really, I wanted to reemphasize that we need to change our language. Right now when we talk to patients we say, well, there might be a drug in 5 years, or et cetera. The point is that there are many things that are interventions, they're not drugs, and need to be treated as useful tools. And it was emphasized earlier that there are lifestyle modifications, there are risk factor modifications, such as exercise, such as an exercise program, such as controlling high blood pressure, et cetera. And to wait for the magic bullet Alzheimer drug and offer patients nothing in the meantime, I think is a disservice. So that would be what I would plead. That obviously all of us should be exercising, all of us should be controlling their blood pressure, but if you have cognitive impairment, you have a little bit more incentive to do that. So, thank you.
I don't disagree. I don't think anybody should wait, but my unique perspective as a stakeholder, as a person who's invested his career in clinical trials, trying to find not necessarily magic bullets, but improvements to our armamentarium. So we do spend a lot of time talking about other things that people can and should do, and I utterly agree that physicians should be carrying that message to their patients.
Hi, as a follow-on to the discussion about the genetic predisposition, would the specialist here recommend that children of Alzheimer's patients get genetic testing, even though that's not a pure indicator, but it's a possible indicator? And if so, what would they do if it did indicate a slightly more positive indication?
I like to let the panel speak. I happen to have written on this topic a little bit. That there's one gene that can be tested for through direct-to-consumer genetic test. It's the strongest sporadic risk gene. There are very different opinions. Most guidelines do not recommend that people undergo that testing because it's not determinant. It's a relative risk. There are different groups who have different opinions about this, groups even that are built upon the idea of bringing more genetics to people, and companies built upon that idea. My personal feeling on this is that the most important message we deliver is that anyone considering undergoing genetic testing for Alzheimer's disease, or really any other risk gene related condition, that they undergo serious education and counseling before they decide whether to follow through with that test, and that they undergo education and counseling after receiving their results if they move forward. There are some unfortunate examples of people misunderstanding, jumping to the wrong conclusions and having very serious responses to the information. And we want to make sure that this is happening in a responsible and safe way as much as possible. That education is largely around how this is not predictive or determinant. Some people really want that information. Some people, when they undergo counseling and education, change their mind. So I don't have a strong feeling about whether we ever should allow it to happen, but I do think that we have to see this happen in a responsible way.
As I've grown older and talking to a lot of my relatives that in their 80s as well as people in 70s and 60s, I often hear about people say, I just don't have the energy that I used to have. And what my question is there any correlation or any study that's been done as far as the thyroid and hypothyroidism and how that can affect the brain?
You know what? That is a really good question, and we're all looking at each other saying maybe
I'm looking
we're
in
not
the audience.
Sure. I can tell you that in the situation with Down syndrome, a lot of people with Down syndrome have hypothyroidism. In fact, close to 70% of people. And of course, they all do develop Alzheimer's disease neuropathology by the time they're 40, but that's more to do with the genetics. I think some of the literature out there does point towards a link between hypothyroidism and cognitive function. Whether that is existing separate from what's happening with Alzheimer's disease in your brain, that's the part of the literature I'm not as familiar with. So if there is a clinician or another researcher in our audience, and we have a great audience, maybe someone has an answer for us.
No?
Obviously, we need to write a grant for this one.
I'm going to call on our colleague, Dr. Ahmad Sajadia, Assistant Professor of Neurology at UC Irvine.
Hello, everybody. As kind of neurologists, we are always told to check thyroid function if somebody comes to see us in clinic with memory problems or cognitive problems. So definitely, I mean, as old as this profession goes, people have been aware of some kind of association between impaired cognition and impaired memory. And also it goes without saying that thyroid problems also lead to reduced energy levels and kind of lots of other things, just becoming slow in general in our activities of daily living. So that might be the link. Also, I mean, in terms of the neural substrates, the biology of how, I mean, thyroid problems can lead to cognitive impairments, there are lots of theories. I would say none of that is established as a fact yet. I mean, there are some promising leads, especially as we kind of move towards later, I mean, parts of age spectrum towards 80s and 90s. We have good reasons to believe that, and actually we know as a fact that thyroid problems become more common. And now kind of switching gears a bit, talking about pathologies other than Alzheimer's disease, as we heard throughout the day, are pretty important, and especially become more important as people kind of continue to age towards the latter parts. And we have some leads looking at the great study called the 90+ study that many of you are familiar with, looking at the associations, and at this point it is just association, and there's a big difference between association and causation, as all of us know. But there is some association between thyroid problems, both medical history of thyroid issues and also blood tests that indicate abnormal thyroid function, that there might be an association with that. And one of the more common and more devastating types of degenerative brain disease is called hippocampal sclerosis that we heard Dr. Schneider alluding to earlier. So we have good reasons to believe that there might be a link between thyroid diseases and different kinds of dementia, and one particular one that we are interested in. But I think we should watch the space on that for now.
So stay tuned. Maybe next year, Dr. Sajadi or Dr. Kawas will be giving a grand lecture on that topic. So I'm going to take one more question from the audience.
You stated that sleeping is important for a healthy brain, but yet there are a lot of people with sleeping disorders. So a lot of prescription meds were being prescribed to sleep, and some physicians are now saying that there is a link between prescription sleeping aids and Alzheimer's. Is that true?
I don't know of a link between specific sleeping medications and Alzheimer's, unless anyone else does here. I mean, as geriatricians, we prefer not to prescribe sleeping medications for other reasons. These medicines are associated with falls, and worsening of memory if you have a memory issue. Like, we stay away from Benadryl like it's the plague. You know, we prefer not to use any of the others. There are very specific medicines two medicines that we may use which have, you know, less interaction and are less known to be associated with falls and memory. So we're not saying that they're associated with developing Alzheimer's, but if somebody does have a memory issue, there are certain medicines to stay away from because they can worsen confusion. And sleeping medicines are some of those.
Okay. One more.
Okay. My question is for the gentleman. Since you've been enrolled in this program, do you feel, excuse me, is that working? Do you feel that your cognition has increased?
I've only been actively in the program about 10 months, and I can't say that it has really increased. Some of the flags that I had memory issues before I even heard of this program, that I recognized myself as flags, was that if I'm calling a company or an entity on the telephone, and there's a possibility they'll ask me what my address is, I always put a piece of mail that's addressed to me next to me so I can not get caught. I know my address as well as anything, but if you just suddenly say, hey, what's your address? I could easily just go blank. Same with my phone number. I would often have it written next to me when I call somebody in case they want to know what it is. I've been very diligent about following the rules that they've laid down for me and going to the gym 4 times a week. I'm very dedicated to that. I've even worked my personal life around those appointments. I am retired and I can easily do that, even though I do help babysit grandchildren, as almost all grandparents wind up doing. But I don't think 10 months is really quite enough. If I can go off on a slight tangent, I didn't hear all of the previous question, but I thought I heard the word sleep mentioned out there. I have sleep apnea. And before I started using a CPAP machine, I would wake up 5 or 6 times a night. Since using the CPAP machine, I wake up at least once, sometimes twice. So the fact that I'm getting better sleep may also affect my memory. But I think at the end of 18 months, if you ask me the same question, I'm hoping I can say, yes, I've noticed a big difference. But after 10 months of this, I really can't say that I've noticed a difference.
Thank you, Richard. So I'm going to give our panel the last word. And since this is a research conference and part of our charge is to think about our agenda moving forward, I would like to ask each of our panel members, from their unique perspective, what do you think we as a field should make our top priority in research in this space? Can I start with you? No. She said no. Dr. Gibbs, can I start with you? Can we listen to the microphone?
She keeps pushing this towards me, so I guess I will. I am the only one up here, well, with the possibility of the Cleo, that is not a medical person. And so it's kind of not likely to result in anything I could respond to. I'm not medical. Half a century ago, working as a combat medic with the 1st Infantry Division was as close to medicine as I've ever been. And that was a whole different kind. So I'm going to defer to the medical people on that.
Well, I want to know what you guys think. So there's lots of different types of research.
Okay.
There's research to improve caregiving. There's research to prevent. There's research to treat. There's research to understand. There's lots of different types of research. What do you think is most important for the researchers like me and others on this panel and in the audience that you want us to know? What should we prioritize?
I can actually say a couple things that I'm very impressed with and excited about, and that is sharing. There's an international group where you put all the Alzheimer's research together, you submit your research, and you share, and that makes so much sense because there could be connections. Somebody could be working on this over here and not have an answer. Somebody's working on the same, has part of an answer. It just makes so much sense to share. And Dr. LaFurla mentioned a national association that you do that, and there's also an international one. I'm very impressed with that. I'm excited about the mouse models. That's amazing that you can do that. You can generate these, regenerate these cells or implant cells in them. And so I'm very excited about some of the things you're already doing. It just seems like we need to go quicker, go a little faster. So.
One of the things that I think would be important or critical to focus on in research is really education to increasing education to our healthcare providers about seeing research as an adjunct to standard of care. Not forgetting that research exists, or maybe we need to do a better job as researchers to educate the healthcare providers that we exist. So that's what I think.
Okay, as a researcher, I think there's two things that I would like to see continue to grow. I know that we're working towards prevention. I think that's really important, and that's probably where a lot of the solution lies. But I also don't want us to lose sight of people who are currently living with dementia. So I think we need to continue developing treatments and ways to manage the disease over the long term. So I see a lot of people in the field as researchers. We're really pushing hard on prevention, but there's two parts to this story, I think.
So before I answer that, I'd like to comment on what you said. And I agree. I think that as primary care physicians and geriatricians, I have patients that are out looking for clinical trials, whether it's at iMind or other places. And oftentimes they'll come in and they'll tell me, well, I'm looking into this study or this study or this study. What do you think? And without the education, I really don't know what to tell them. So there does need to be better communication and linkage between the researchers and the clinical trials and the people seeing older adults, absolutely. I could tell you what we're involved in at UCI. So our research from a division of geriatrics, includes the gamut. We're interested in developing a dementia care communities. We are in the process of developing age-friendly health systems. We currently have the support of UCI Health to develop age-friendly, which means that we're going to concentrate on 4 M's for every patient. We want to know mentation, mobility, medications, and what matters most. And that means that the discussion of cognition and mentation and memory issues will be commonplace, and we can reduce the stigma for patients that come in asking these questions. So I'm really excited to be helping to lead that charge for UCI Health, and we want it to be a very friendly and accessible place to go. We want to make Orange County dementia friendly as well. So we have some research and outreach into a lot of the Orange County nonprofit organizations to help us do just that. So a lot of innovation, and I think also at the grassroots level we need your help, we need patients' help to demand that we have physicians that know what they're doing when it comes to assessing and evaluating and treating dementia. We really need the grassroots push because there are so few of us that we need that support so we can be sure that we're educating our medical students and residents and fellows on how to do this properly. So the aging, the demographics are here. We're way behind the 8 ball. So anything you can do to help, push us forward and demand that you get proper care is what we need as well.
So before we thank our panel, I just want to make a couple of quick announcements. We're about to take our last coffee break. If you are an exhibitor, we have 2 great talks remaining, and we hope you'll stay for the duration of them and not take down your exhibit until both talks are completed. If you're a person who needs CEUs, at that time, at the end of the last talk, you need to sign out. I'm told this is all or nothing when it comes to CEU credits, so you have to be here for the duration. I think we should all give a tremendous round of applause to each of our stakeholders for sharing their perspectives.